Dear Pure Urology viewers, good evening one and all. Today we are discussing about laparoscopic nephrectomy. As you all know, many years back, maybe 20-30 years back, Professor Kauk and everybody started with laparoscopic nephrectomy. Nowadays, in the present era, nephrectomy can be of two types. One is radical nephrectomy, another is simple nephrectomy. Radical nephrectomy today we are not discussing. In fact, more easy to do because the planes are well maintained unless lymphadenopathy is severe and inflammatory reaction is severe. But simple nephrectomy is done for non-functioning kidney, predominantly for stone disease or any other inflammatory disease which affects kidney like GUTB, xanthogranulomatous pyelonephritis, pyonephrotic kidney, etc. Definitely, it is not simple nephrectomy. To speak about these tips and tricks, experienced surgeon from Nepal, Dr. Parash Shrestha, who is a national and international renowned person in laparoscopy. He will be talking about the tips and tricks, how you proceed in difficult cases. Let me introduce Dr. Manish Shrestha and then I will hand over the program. Rajendra, can you share the PPT? So today topic is simple laparoscopic nephrectomy, not so simple. It is absolutely correct. So Dr. Parash Shrestha, Professor of Urology at National Academy of Medical Sciences, Department of Urology, Bir Hospital. He completed, in fact, his urology residency at BSMMU Dhaka in Bangladesh 2023. He was trained as fellow at Singapore General Hospital, Department of Urology from 2004 and 2006. The same period, even I got my urology training. He is a founder member of Nepal Association of Urology Surgeons now, NAUS, and is currently the president of the association. It's a very honor today that we are having him as the speaker. His main interest in urology include endourology, laparoscopic urology, and renal transplantation. As you all know, we have visited Nepal many times, and in this country, recently, urology has picked up like in any other Asian countries, and they are a par with any Western countries in doing the advanced procedures. Dr. Manish Shrestha is one such a professor and invited faculty in the national and international level. With this introduction, I hand over the program to Dr. Professor Manish Shrestha. Over to you, sir. Thank you very much for joining the Pure Urology.
Hello, am I audible?
Yes. Yes, sir.
Can I share my screen?
Yes. No problem.
Okay. Is it there?
No. No problem.
It's I already start sharing, but
no. You stop it and then restart, sir.
not at So I'm waiting from your side to restart it, right?
No, you
share, sir.
yeah, share screen. You click first, and then re-go.
Okay. I've already started sharing.
Close that, sir. You go to.
Click on the share option, sir, on the Zoom. You go to Zoom
Yeah,
and click on
share,
the click on the Zoom.
Yeah, I have clicked and
and you select the
multiple participant can share one participant. Which one is it?
On the down, share the screen will be there, green color.
Green color.
Yeah, down it's here. I've already clicked it. They are giving me option.
You are the co-host.
Oh, okay, share.
Yeah, now you are shared. Yes, thank you. Nice. We don't have any time limit. You can take your time. We are 7 minutes delayed today. Sorry for the audience We usually start at 5. Due to technical reasons, we could not start at 5. Please, sir. We are able to see your full screen.
Okay, shall I start?
Yeah, please.
Okay. Namaskar from Nepal. I am very privileged that Preeti Urology and our very renowned Dr. Chandramohan Bhadi has given me this opportunity to share my small experience about simple nephrectomy. Um, I think I'll just go on with my talk, and I hope we can share our experience along with Dr. Bhadi because he is a very experienced surgeon. I would like to hear some of even my queries he could answer. Um, the topic is laparoscopic simple nephrectomy, anything but simple. So if we look at the meaning of simple, means that it is readily understood, readily can be performed, which is exactly opposite of difficult, hard, complex, and complicated. In fact, in urology, the radical and simple nephrectomy terminology is used to refer to the surgery for malignant and benign disease, respectively. So, so we have this experience when we all started our laparoscopy. We tend to do, of course, we tend to do ablative procedures rather than reconstructive procedures because we all always think that it is simple, and we embark with simple nephrectomy. I think we all share this experience, and simple actually implies as an easier procedure. Perhaps we always think that radical surgery itself is difficult, and we all as a starters, especially the beginner laparoscopy, we tend to avoid radical surgery first, and we always tend to go to the simple nephrectomy first. But looking at the history as early as the pioneers, Dr. Gill et al. In 1995, they have realized this problem that simple nephrectomies cannot be, is such a big spectrum of surgeries in one particular name. So they tried to have this grouping of different levels of simple nephrectomy according to the renal pathology, and along with the technical difficulties we're trying to define so that you are mentally prepared what kind of surgery you are going to face today when you are going to do it. So conditions under which the the first one is easily accomplished category, which are small non-inflamed kidneys, such as renal artery stenosis, medical renal diseases, and reflux nephropathies, and the intermediate level difficulty like non-functioning hydronephric kidneys, chronic PUG obstructions with some inflammations, of course, and massive reflux nephropathies, which are associated with recurrent pyelonephritis. And the third, which is considered the very difficult laparoscopic nephrectomies, are xanthogranulomatous pyelonephritis, because these kind of nephrectomies are associated with severe perinephric fibrosis and other adhesions around. So just looking at our data, when we just started in 2006, we started late in Nepal. To 2016, I started doing laparoscopy in my institutions, and looking at our data within first few years, our conversion rate was around 5%, and which was quite similar to the other series published. So let me start with sharing with this small video of mine. So this is the left-sided simple nephrectomy, and this is what we do at the first step. We try to peel off the fat and staying just outside the Zerotas fascia. But you see, more you do it, you realize you are not able to peel it down, and it bleeds anywhere you touch. So when you are in the right plane, you normally don't bleed like this. You see? So, and the problem with laparoscopic, you don't have tactile sensation. So, but with the instrument, still with the instrument, in this case, we could feel the hardness of this pyelonephritic kidney. This was pyelonephritic kidney, which we converted later. And more you go on to trying to do this very simple first step of simple nephrectomy, the things are not going down, and you can see you can make these kind of holes, and you are not able to go into the hilum. So the idea is of all this dissection is to peel away the bowel and go into the hilum. If we cannot accomplish this first procedure, then you have to realize you may not be able to proceed in a laparoscopic way. You may have to do open. So are they factors that we can have in our mind to predict before we start the simple nephrectomies? So first thing is, of course, infection. And infections that, you see, all the procedures we do, either open or laparoscopic, we surgeons are um, navigated by the surgical planes. And if we stay in the surgical correct planes, we will bleed less. But all these planes are destroyed once you have ongoing or past surgeries or past infections, and which will destroy these planes, and our job will be very difficult. So persistence of inflammatory process is common associated with less distinctive surgical planes. Friability of tissues, like you saw in this video, it bleeds anywhere you touch, because in this case, maybe the inflammation was still going on. And all these changes increase the challenge for successful outcome of any laparoscopic surgery. So let me share with this very important paper from Nadia by Dr. Manish Desai's group. They have this prospective study of preoperative factors predicting the intraoperative difficulty during laparoscopic transperitoneal simple nephrectomies. So they have suggested that if there is presence of pyonephrosis in preoperative imaging and a BMI of less than 25 kg per meter square. This is a bit of surprising factor. I realized that BMI of having less would have, these factors can predict that you will have more difficulty while doing simple nephrectomies. And they also found these other factors, like if you have a palpable kidney before we start, if you have history of renal intervention, perinephric fat stranding, right side more than left side, and fixity of the kidney during ultrasound to the surrounding tissue. These can predict that you are going to face a difficult case. So one of these papers, which has focused basically on inflammatory markers with the radiological findings, they have focused on CT findings like perinephric stranding, thickness in Houn's units, especially Houn's unit of kidneys and pelvis. So radiological finding using this CT can predict the preoperative adherent perinephric tissue, and we can uh, predict that we are going to have a difficult surgery. So what's about the past surgeries of the kidney? You see, even when we started at the beginner, when any patient, because all these patients with nephrectomies would have, like Dr. Vadi just said, like stone disease is very common. These may have open surgery in before, not like now. We have RIRS now, we have PCNL, but at that time, most of them people have some kind of scarring of open surgery. So initially, when we even started, it was very difficult for us to even embark on these cases that, oh, this has open, maybe we will go for open rather than laparoscopy. But with time and with all the newer instrument we have, and of course with our experience, we are better in this. But these cases normally have high likelihood of access related complications, organ injuries, and difficult tissue dissections. And this is a paper from Great Britain. So they have found that the risk of the injury of the blood vessels and the viscera, especially the bowel, is more while doing insertion of laparoscopy port, more during these cases. And when we have this kind of injury, the associated mortality is pretty high as 7.8 in their study, especially when you have blind port placement. So in these cases, you may have to rethink before you put it blindly. If you're not sure, maybe you have to uh, put your first port at least with the open Hassan's technique. So how about PCNL? We think this PCNL is a very simple. It won't cause any problem because it has got only one scar maybe you'll have easier nephrectomies in these cases. But however, PCNL, well, not well, they will always have irrigation fluid leakage, urine leakage, and of course, retroperitoneal hematoma. All these can ultimately lead to the adhesions, and we will make these cases difficult while doing it. So presence of stone. I think this part is people should really keep in their mind. When you have a nephrectomy with stone and without stone, the picture should be dealt a bit differently, because the pictures are pretty different. So in developing countries like in South Asia's, like Nepal, even Africa, and maybe South America's, most of the countries, they have non-functioning kidney, most of them due to stone disease, not because of other diseases. So as high as 50 to 60%, even in one of the studies we did, we have the similar high percentage of people have nephrectomy due to the stone diseases rather than malignancy, which is common in the developed countries. So, so in these cases, there are dense perirenal and perihilar adhesions due to the stone and accompanying infection, making visualization and anatomy plane quite difficult to reach to the hilum, especially when the stones are nearer to the hilum, like in pelvis, PUJ, right at the time when you want to go into the vessels. If the stones are maybe down in the mid or lower ureter, you may not face this problem. But in the stones nearer to the hilum, you will have more problems. So I'm going to share one of the studies done by us in our department. This is a prospective evaluation of preoperative factors to predict that intraperitoneal difficulty during transperitoneal laparoscopy during simple nephrectomy in non-functioning kidney due to stone diseases. We look at the different factors in the during nephrectomy in the stone disease. Within 1 year, 92 patients, single surgeon experience, and at the end of the surgery, the surgeon will assign different level of scoring in, like in mobilization of colon, dissecting vessels, hilum, clipping and dividing them, freeing the kidney all around, and identification of ureter. So these are range from easiest to the most difficult, the 1 to 4, and this is scoring. We adapted from Gujarat and Ratnakar Atel studies. So we found that one of the most important factor we have difficult when you have these cases with pyonephrosis, and all these difficult cases would have longer surgical time, more blood loss, more need of staying in hospital, and of course we have to put the drain in the selection of putting the drain in these cases, and taking with the drain they will stay longer with us. So our study concluded that patients with pyonephrosis have a longer duration of surgery, higher blood loss, and out of these patients, 4 patients required open conversion who have pyonephrosis, and they have higher complication rate and longer duration of stay with us. Now, this comes rare, but still we face time to time xanthogranulomatous pyelonephritis. It's a typical chronic renal infection which is basically destroys the renal parenchyma in the surrounding tissues, have these masses of lipid-laden macrophages. They often mimic neoplastic infiltrative character when you operate, and these are associated normally with stones, obstructive uropathy, and ongoing urinary tract infection with different types of bacteria. So if you go back and look at the earlier pioneers like this Clement, the contemporary laparoscopic surgeons, so many things we still follow them. They initially in 1919 they say no, xanthogram paranephritis should not be approached laparoscopically. You'll have more complications, you'll have more problems, and maybe it is better to do open surgeries without trying for laparoscopic. But now things are changed. You look at this one of the papers from Israel. They have say yes, we can still do nephrectomy doing laparoscopically, doing using our skill, and of course new energy devices and dissecting instruments. It is still feasible in some cases. You see, they're still very skeptical some cases. So does the size matter? If the kidney is big or small, yes, it sometimes matters. Sometimes we may not be able to do transperitoneally. Well, I don't do retroperitoneous nephrectomy, but there are papers that say it is easy. They have said that easier with the retroperitoneal approach in these cases, and they even has reported using morcellators, removing these chunks of tissues while doing this kind of nephrectomies. The another big factor in the, especially while living in the countries like Nepal, the South Asian, we still have these GUTVs we have to face, and when we do laparoscopic surgeries, they were relatively contraindicated before, mainly because of two reasons: because there are a lot of fibrosis and they have higher rate of conversion, and one of the most important factor is these cases while doing, if you are not careful, if you cannot get the correct plane, maybe you will spillage of this caseous matter within the abdomen, which will disseminate the disease. At least theoretically, there is a possibility. So these surgeries still, we nowadays, as I am telling you once and again, that with all our skills and all that, we still can approach, and we can still have a very good outcome of nephrectomies in renal tuberculosis. So there is one database brought out in UK, looking at their database of 1 year in 2012. The patients were within registered Bausch urological surgeons of nephrectomy data, about 1,000 cases of simple nephrectomies. They have showed significantly increase of conversion to open, 1.8 times higher requirement of blood transfusion in simple nephrectomy compared to the radical nephrectomy, the T1 disease, respectively. Furthermore, intra and postoperative complications and blood loss were also higher in simple nephrectomy than in radical nephrectomies. And the result of this study also showed that the patients with stone disease had higher complication rate than other nephrectomies with the other etiology, and conversion was pretty high with the stones and infections. And they ultimately, in this article, has suggested that shall we change the name of the simple nephrectomy to the benign nephrectomy, so that the mindset of the people to the simple nephrectomy procedure will change and would not take it so lightly. So there's one score that has been devised, Mayo Adhesive Probability Score, which was actually uh, devised for imaging-based scoring system to predict adherent perinephric fat in partial nephrectomy. But we still can use this in Mayo Advice score. This score is based on adherent perinephric fat and strandings, and they basically focus on posterior, lateral, and renal vein level in the CT. So with that, you can have a scoring system according to the perinephric fat thickness and also perinephric stranding. So different points are given according to the severity of stranding and the thickness. And with that, you can have a prediction that higher score will have a higher difficult cases you will be facing. So we also had study in our department with this scoring system in laparoscopic nephrectomy. So we concluded that high MAP score are seen in male gender, high BMI, and the patient undergoing with the patient with this patient going simple nephrectomy, and high score is associated with prolonged operating time and perioperative complications. And this MAP score you can use before surgery, and we can predict that what kind of surgery you are going to face in that particular case. So end up my talk, I would like to conclude with saying simple may not be presumed simple, and careful assessment of these cases of laparoscopic nephrectomy for the benign cases should be done. We can use different parameters and of course your experience to make yourself prepare for these cases. So different factors which I have mentioned should be guide you to predict the difficulty during this laparoscopic transperitoneal simple nephrectomy in such cases, and the most importantly, conversion to the open in difficult case. Never hesitate. Just go ahead. This is not considered failure. Actually, this should be considered a good decision in terms of safety and the total outcome of the surgery. Thank you. Thank you, Preeti Urology, for giving me this opportunity. And I would like to hear our experience from Dr. Vadi, as he has done many more surgeries than I have done. So let's hear from you.
Yeah. That is very crisp presentation. Very good words you have used. Very good grammar. I don't know. All the Nepalians usually speak good English and good accent and good English. Thanks to your schools and teaching. Anyway, I wanted to discuss one by one, taking your experience and my experience both into consideration. The first one is, do you think the fat distribution around the kidney in the CT scan, especially around the renal vein IVC border, in the right side, if we have a space, a thin line of plane, if it is present, does it indicate a less fat, indicates it's a okay acceptable case? Do you look into that first before going? What is your opinion?
So thickness of his fat and of course the stranding related to the history we always consider, and we would predict that we are going to have difficult case. But as you said correctly that you see there is always one layer of fascia covering the vein, especially vein rather
Yes,
than artery. Artery there are a lot of lymphatics. In veins, if you can reach that level of fascia just outside the vein, you'll always have your plane, no matter how
yes,
much fat you have outside.
correct,
But
correct,
in
correct.
the
I understand.
artery, but the right in the artery is different. Artery, you will have lymphatics one layer after another. It depends on how much of a reactive or whatever region you have lymphatics. Normally, you don't see that particular fascia in artery, in my experience. I mean, but
Yeah.
still, once you reach the outer layer of artery, you can still dissect out whatever lymphatics around it.
My second question, during simple nephrectomy in open surgery, we will try to be close to the kidney, even the hilum. Wherein in laparoscopy, if you go close to the major vessels like radical nephrectomy, you are slightly better. If you go intragerotal, it is much more difficult than extragerotal and removal of, especially if you have a thin rim of plane directly going extrarenal. That is also like the case you have shown. The peritoneum, if it is adherent so much, uh, even then going on to the psoas by the side of the aorta or IVC and slowly going on the psoas and then coming back to the front so that you will get a nice plane to the renal vessels is better, or you will go intrazerotal and go to hilum. What do you feel? What is the junior should try the inflamed kidney entire thing? You go outside and try to get the neck by holding the vessels and then get away faster, is better. Which is better?
Uh, the schooling we have got always, you see, our teachers say doesn't matter you are doing benign or radical nephrectomy, always try to stay outside gerotas. That's the school of thought. That's the
Great. Great.
because you will have less problems.
Yeah, yeah,
But
yeah.
in simpler nephrectomy, as you said, it is not as simple as that.
Yes,
See,
yes,
is always there is at some point you may not be able to proceed like that. Normally,
yeah,
we like to proceed from like in the left side, maybe once you lift up the ureter with the gonadal packet, then we
yes.
eventually go and stay outside. That's okay. But as you have correctly said that once that is not possible, then you may have to try to get the vessels first, because in these cases what happens is if you are not like the kidney is sticky here and there, if you are not have
Fixed.
yeah, if you don't have the vessel control, then you will be in trouble.
You will be
You
in
don't
trouble.
go anywhere. You just try to get the vessel first. That may be one of the way. And other technique, I think I have seen some of the Indian surgeons experience. They describe so-called two-window techniques, that you
Yeah,
get the window from down and you go and you just push down. Maybe if you are lucky enough, suppose on the left side, if you see the left adrenal vein, then you create a window just above that and
Yeah.
lift the kidney on the both side.
Yes.
Then you will be in a safe place.
Very
That
safe position. Even if you open, you can pinch with your kidney, your renal hilum, and somehow apply artery forceps or any instrument. As a matter of fact, even the stapler. But if you don't have that plane, and if the kidney is fixed, and if something is bleeding, especially vein, it's disastrous even in open.
yeah.
Then you have to really go with subcapsular nephrectomy in a dire emergency.
So the
Yeah,
thing is,
my
the thing is, being a laparoscopic surgeon doing nephrectomy, your key aim is to hilar control.
hilar, get
Whatever
into the
happens
center.
around you, it's not like
It's not like
You
yes.
just have to find the vessel. So the typical way of doing it, you may not be able to follow in radical. Radical is normally quite straightforward. You just
Quite
follow the
straightforward.
plane, you will get there.
Yeah. And my third question, in case if you feel hydronephrotic or pyonephrotic kidney, do you think that placing 2 weeks of PCN reduces that inflammation in the fat and makes it dry? Anyway, it is difficult. Anyway, post pyonephrotic kidney is difficult.
Hmm.
But sometimes intraoperative opening of the pelvis and spillage makes you hurt that you can't proceed at the same time. You even if you convert, it's not easy. Sometimes less experienced surgeons in the present generation may feel more difficult with open than lap. For example, 3 years if you are trained with laparoscopic surgeon, and suddenly if you want to open in your private practice DNB or MCH students, it may be really, really difficult. The question I am asking is drainage of the kidney before nephrectomy versus second point, taking a senior when the case is open nephrectomy, somebody senior should be there. Otherwise, sometimes it is it's mortality range cases. These are
So, so there are two factors you just mentioned. One is pyonephrotic, other one is hydronephrotic, the which occupies the space. One, no matter how small or big, you still have infection, pyonephrosis. So what we practice here, if it is pyonephrotic, especially if the patient is symptomatic, we will wait with PCN.
yeah.
But practically, for the patients in a tertiary hospital like us, they don't have time. They will come
Yes.
and they say, we operate, I have to go back. They have only one shot. They will not wait for 2, 3 weeks. And even if you put a PCN, this PCN tends to fall out because they don't know how to take care of.
Yeah. They tend to follow it.
So you see, no matter how much theoretical this thing you have, the practical point is you may have to go without PCN most of the time. Number one.
Yes.
Number two, keeping in mind while we are doing dissecting kidneys around it, uh, do not do not puncture the kidney or try to make it smaller before we get the correct plane, and try to, if you have dissected as much as you want and you have already seen the hilum, then you can always make
Then
a
we can
puncture,
always.
make it
Yeah.
make it small. That's a different thing. So the idea of pyonephrotic kidney is always keep in mind that you are going to open it. And
Open.
open these cases normally are, as you correctly mentioned, is subcapsular nephrectomies.
Yeah.
This,
Yeah.
and if you don't have the experience, you'll be in trouble.
No point. That's a proper strong message that if you have never done subcapsular nephrectomy, it is an art with your finger. There is
Yes.
not much art with your finger and right angle forceps.
Yes.
Not much energy sources can be used. You need to do ligation. You need to use silk. You need to have bold, quick silk ligation, and sometimes quick clamping with a log artery forceps, and then suture with 3040 prolin. Also, you should have those skills. Running the horizontal mattress or the fixing sutures onto the hilum are sometimes essential. You may not get proper artery and vein properly separated and all that. So they are really difficult. I think
Yeah.
that's one of the most difficult cases in urology is actually GUTB or xanthoglandomatosis pyelonephritis nephrectomy. Not even radical prostatectomy and partial nephrectomy. If you practice 5-10 times, you can do it, no problem. If you have a mentor, same prostate, you remove anastomas. But pyonephrosis, even for mentor, on that day he needs luck, and he has
Yeah.
to he has to be keep his nerves taut, because bleeding before renal ileum is identified. If you keep on sucking, the blood will go, and till the specimen is out, bleeding will happen. The moment you remove the specimen, entire bleeding stops. So removal of the specimen early is also important. Yes, sir. Please tell me.
What I was trying to, Dr. Vadi and me, maybe we are that lucky generations that we were trained open surgery before laparoscopy. You see, we are trained to uh, do subcapsular nephrectomies. Hello, am I audible?
Yes, sir. Yes,
Ah,
yes. We are with
so
you.
the problem with our new resident who are never exposed to open surgeries, subcapsular nephrectomy is one of the most difficult
Most
thing they
difficult.
would.
Most difficult.
So I think we are trying now to let them do few open cases and try to make them understand this subcapsular nephrectomy is something you should always have to keep in mind in,
Yes.
in the simple nephrectomies and get ready for it. And as you
Yeah.
all said, all this very quick,
Yeah.
take a
You
suture,
can't.
put a clamp, use your
Yes.
hand, pinch it here and there is very, very crucial to finish this surgery.
Yeah. So one important question for all the urologists, greatest route map is the SOAS. If you are in very difficulty, something play on the psoas and get above and below the hilum. Do you think you believe that go behind the kidney, sometimes uh, daringly flip the kidney and go behind to get the hilum? Is it sometimes required, or you feel better to open before doing that?
So I normally don't do that, the flipping of
You
the,
don't do that.
unless you are doing partial nephrectomies, laparoscopic partial nephrectomy, when the
Yes.
tumors are on the posterior sides. Otherwise,
Yes.
flipping kidney in such cases would be quite risky because you don't have control how much instrument you're poking anteriorly, because there
Yes.
are a lot of things, because SWAS give you the background that you are in safe area. You don't poke no matter how much you poke, it will be the muscle.
Yeah.
But once you flip it, then you will be you don't know how much tissues, bowel or other vessels are in front of you, actually on the
Yes.
back of you once you flip it. So
Yes.
I would not dare to do that. If you have experience, maybe sometimes you have to do that.
No,
I'm not against it.
I also in inflammatory diseases, you are correct. I don't recommend flipping. It's not easy. It's a heavy kidney. It's inflamed kidney. Every bit will be adherent. It will take lot of time and bleeding will be there. You lose blood. Instead of that, lower pole identification, ureter identification, lift it heavily over the psoas and go towards the LM is much better than complete flipping without reflecting the colon. So reflection of the complete colon and keep the bowel away is the first principle. We can't escape that. In that case, if you cannot do it, decide early in the beginning only and go right onto the gerotas, open it and separate, and with finger go onto the hilum, pinch it and do it is better than doing mesh up these things. Ajay, one more question I have. Sometimes when you get plain above and below hilum and you think that everything is okay, but you are not able to see the vein and artery separate. You are trying. In these cases, slightly recently, I feel 2 3 cases, stapler which is of 8,000 Indian rupees is worth if you have a space above and below, and if you can compress the tissue, not very thick tissue is present. Don't bother about anything. Just make sure that bowel is away and superior mesenteric artery is not coming. As lateral as possible, fire it off. Have you ever tried that?
No, I don't use that instrument. But
Yeah,
as you are said, we have cases when you
yeah,
cannot find the artery. The vein is in front of you, you cannot find the artery. You see,
yeah,
it's
yeah,
sometimes just right behind or more
yeah.
normally on the upper
Upper
margin
part.
of
That's
margin.
dangerous.
Very dangerous area, because you don't know. So in these cases, maybe you have to try to go more posterior laterally, and you try to push away the kidney a bit if you have a complete dissection on the lower pole, and try to see the artery. Even if
Artery.
you don't, if you don't, if even if you cannot put your clip or somewhere, if you are lucky enough, maybe you can use your bulldog or something just to
Yeah,
pinch it for a while and leave it for a while. Everything
yeah,
comes down. Maybe
yeah.
after that you can put clip on your veins,
Yes,
take it out because artery is already stopped. The vein will
yes.
collapse. Then you can put your hemlock over.
That's a very good idea. In fact, I used to you told better bulldog, long bulldog. I used to put Satinsky and cut it off. Two
Okay.
Satinskys or one Satinsky, like in open surgery artery, with a good chunk of tissue left behind. But it's very dangerous step. When we are doing that, you should be ready to open in minutes or seconds to quickly control, because Satinsky, these instruments sometimes slip and
Yes.
they retract the tissues and they go behind in the fatty tissue behind the aorta and IVC, and the continuously blood will bleed. So we should not casually attempt transecting the artery and vein by clamping. Open surgery it is different because you can hold with the hand or
Yeah.
somebody can retract.
True.
Even aorta can be retracted. Unforceably, artery forceps can go between behind the aorta and clamp it. But in laparoscopy, however good you are, the vision gets obscured, blood accumulates, suction person will be different, retracting person will be different, you will be shouting, and in no time, blood loss happens and mortality happens. So I feel a stapler, if it is not separable, I have used 2 3 times, very handy, cost effective. But Satinsky application is dangerous. But bulldog, even if you apply bulldog, if you separate the vein and artery, it's okay. If you cannot separate,
Then
cutting
you
it blindly
no, you cannot.
is dangerous. Is dangerous.
You cannot.
Last few questions. Uh, you have tendency to open the pleura in these cases uh,
Okay.
because we try to go outside the plane towards the spleen and then go more posteriorly. Posteriorly, suddenly you'll see opened cavity where you can see lung also. You get sort of disheartened by seeing this pleura opening. Do you think it is a major consequence, or just with the catgut or vicryl you can suture it nicely, especially with the tissue along with the muscle lateral wall, just simply tuck in and come out is okay?
So it depends, you see, it depends upon how big is your hole.
Yeah,
And once you make a hole in pleura, the first thing is you talk to your anesthetist.
yeah,
Tell him is he able to ventilate or not, okay? Because
yeah,
these are creating negative pressure. There are some oozing around.
yeah, yeah.
And they not only tend to suck air, they tend to suck all the blood. And it's not
Blood,
pneumothorax, it's a pneumohemothorax. So
pneumothorax.
if it is small, as you said, you can just straightforward stop your procedure, go there and put sutures, and ask your anesthetist that is the what we call intra cough pressure is okay or not. They will tell there's very high pressure. Then you realize the pneumothorax is or the hemothorax is high, is much larger than you think. In those cases, after putting sutures, maybe intraoperatively, or if the anesthesia allow, after surgery you put a chest tube. Most of the time we don't put. When we have these cases, we small one, we just put sutures and come out and see clinically, basically clinically, if the patient is well ventilated, and we do immediate X-ray. Sometimes we put see most of the time we put chest tube after the procedure, because
Okay.
most of the time these are not big. These are small, like you said. If you are smart, sometimes we realize very late. At that
Yeah.
time, if you do work for half an hour, a lot of blood, and this thing has
Yes, yes,
already gone to
yes,
hell,
yes.
then
By that time,
you will have a lot of problems.
problems. Last question. If any bowel is injured, if three options like experienced persons can suture the bowel, especially small bowel. Uh, Number two, open and call GA surgeon and help of the GA surgeon without hesitation. Uh, these two options, how do you take medical legally? How do you consider in private practice? If bowel is injured at any point of time, especially with fecal matter, you have not done great bowel preparation, you have taken it lightly. So better to open and do it for a junior.
Okay, let me share our experience. In last 10 years, we have lost two patients, and
Oh,
it's because of the duodenal injury. One was realized late, one was done by a junior. One was realized at the point, He didn't actually, we didn't lose the patient, but the morbidity was very prolonged. Few months he was with us. With the help of GI, sir, went to repair. Still, we had problems. So it is all depends upon how is the extent of your injury, which part of the bowel, how which energy device, or the simple cut. If you don't have energy device, mostly you can repair the small ones with the laparoscopy. We have repaired quite few, and the outcome is fantastic. Of course, whenever you have doubt, don't be so hero. Just call your GI partner and let me have a look. He will decide. Okay,
Yeah.
it is field.
You will be mentally relaxed when somebody else will come.
Definitely, definitely, and of course,
So you
medical
should not
legal.
use your ego, or you
No,
should
no,
not take hasty decision
just
also,
just throw it away. Call your. They are very
and
experienced.
relax.
Yeah,
Because 15
and
minutes
relax.
additional time, 15 minutes additional time will not make any difference.
No difference. Initially, when I had similar problems, I opened it immediately myself, and I repaired myself because it was small. But now I don't do that. I can repair it on table with the laparoscopy, of course. But
Yeah.
these cases must be discussed with the patient, because after losing one patient, we are really now.
Yeah, yeah.
And
See, after the on-table bleeding, which can lead to mortality, second major morbidity is on-table bleeding. At least either settles or goes. On table it will be decided. But morbidity of the bowel leak is phenomenally takes out the energy of the surgeon, team,
oh,
hospital, patients, attendants.
everybody.
So, at any cost, energy sources should not be used nearer to the bowel. Go as close to the as kidney. Your eyes should know where can be bowel present, where very fast movement should be avoided, very slow towards the kidney, and any doubt, open surgery is better. So repeatedly, we both are enough seniors. Still, we are going back to the principles that involve the expert early, open early, use multiple ports. Don't keep or assess quickly that whether you can do it or not. Also, doing for 3-4 hours and then decide open again 3-4 hours. It doesn't
No
serve
need.
any purpose to the patient. Instead, just simply accept that it is difficult for anybody. It is difficult, however senior, however junior he is. And especially the message to the juniors, I wanted to particularly take this topic after discussing with Dr. Manish Shrestha, that our nerves should be kept at low and ego should be kept at low to open first.
True.
If you are not good at open, even if you don't get any money, even if you give all the money to the colleague senior, give it, observe it. If he has done well, learn it, and then close properly. Abdomen also should be closed properly under good relaxation. Thorough wash has to be done, and proper suturing has to be done, and adequate hemostasis has to be done. One or two drains also to be cared. Post-operative, meticulous post-operative care is important. Hypotension, noradrenaline treatment is also important. Urine output, continuous monitoring for 2 hours, because unknowingly you might have sucked a lot amount of blood. Anesthetist also may be casual. He may not tell you. Hemoglobin repeat may come 7, 8 in the next day from 14. So that says you can give blood, but that's not the answer. So with this, I must thank Dr. Manish Shrestha for giving these excellent messages, and I am also happy that I could conversate with you. And let's hope the session will be useful for the juniors. Thank you very much.
Thank you,
Thank
everybody.
you. Thank you. Great.